Hey, my name is Krista Lynn Williams, and this is my YouTube video for Auburn University on atrial fibrillation, commonly known as AFib. So AFib is the most common type of arrhythmia encountered in clinical practice. It's a supraventricular tachyarrhythmia in which the heart's conduction system produces rapid, disorganized electrical signals, causing the atria of the heart to fibrillate or contract quickly and irregularly. This causes pooling of blood in the atria and incomplete emptying of blood in the ventricles, predisposing an individual to thrombus formation. The loss of atrial kick, along with a rapid ventricular rate, can also lead to serious hemodynamic instability and decreased cardiac output. There are various categories of AFib, including first detected, persistent, paroxysmal, and permanent. So who's at risk for AFib and why? At-risk individuals include those with cardiovascular factors such as hypertension, coronary artery disease, heart failure, and rheumatic heart disease, also if they have any other type of arrhythmia. Pulmonary risk factors include those individuals with any recent acute respiratory illness, such as pneumonia, anyone with chronic lung disease, sleep apnea, or a history of pulmonary embolus. Metabolic risk factors include diabetes, hyperthyroidism, and electrolyte imbalances. Also, a history of recent cardiothoracic surgery is a risk factor, as studies show that approximately 60% of individuals develop AFib after valvular surgery. So 3 key questions to ask in your workup of this diagnosis and why. So if you suspect someone has AFib, you want to ask questions that review their symptoms, health history, and medications. First, ask questions that inquire about the onset, pattern, and duration of symptoms because you want to determine the clinical type of AFib. Next, ask the patient to describe their symptoms. Do they feel palpitations, like their heart's fluttering or skipping a beat in their chest? Are they short of breath, dizzy? Have they had near syncope or syncope? Fatigue, chest pain, leg pain, or swelling. Third, you want to ask questions that review their health history and medication history, such as do they have a history of AFib, any other arrhythmias, coronary artery disease, hyperthyroidism, or heart failure. Also, have they been sick recently, and have they started or stopped any medications, such as abrupt discontinuation of a beta blocker. As far as the physical exam, the most important components you want to look at is initially look at vital signs, noticing the heart rate and the blood pressure. Assess the general appearance of the patient. Are they pale, diaphoretic, and dyspneic? You want to perform a thorough cardiovascular and pulmonary examination, auscultating lung fields, noting any adventitious lung sounds that could indicate respiratory complications. Auscultate the heart, noting the rate and the rhythm. Listen for murmurs that could indicate a valvular disease or a pericardial friction rub. Assess for jugular venous distension, irregular pulsations, and auscultate for carotid artery bruits. Obtain an EKG so that you can further assess the type of arrhythmia and note any current or previous damage to the heart that could be from an MI. Lastly, perform a thorough neurological examination because AFib can lead to stroke and cause cognitive changes in the elderly. So the most common treatments for AFib, the goal of treatment is rate control and symptom management, prevention of cardiomyopathy, and prevention of thromboembolism and stroke. Patients diagnosed with AFib should be managed by a cardiologist. Rate control is typically achieved with medication therapy. It could be single or combination therapy, typically with use of calcium channel blockers, beta blockers, and/or digoxin. Calcium channel blockers, such as Cardizem or Verapamil, are commonly prescribed because they reduce both the resting and exertional heart rate, thereby improve exercise intolerance. Beta blockers, such as metoprolol or atenolol, block AV node conduction and counteract increased sympathetic activity. This drug is beneficial when AFib is associated with activity, hyperthyroidism, or MI. They're also the drug of choice for patients with CAD and systolic dysfunction. Digoxin is used to slower the ventricular rate and may be used in combination with calcium channel blockers or beta blockers, but it's no longer considered first or second line therapy for rate control in patients with an ejection fraction greater than 40%. Also, the patient needs to be on antithrombic therapy to prevent stroke and embolic complications. Choosing the appropriate antithrombic therapy, such as an antiplatelet like aspirin or an anticoagulant such as Coumadin or Pradaxa, is based on patient risk factors, comorbidities, and provider expertise. Cardioversion may also be performed under the direction of a cardiologist to try and restore normal sinus rhythm and control the ventricular rate. So the 3 things you really want to teach your patient. First is lifestyle modification. They need to avoid or stop smoking, consume a balanced diet, limited caffeine, and limited alcohol. Second, the importance of medication compliance to control symptoms, heart rate, and prevent stroke. Make sure the patient has the ability to get their medications and that they understand the importance of taking their medications as prescribed. Discuss symptoms that would indicate the need for emergent care, such as sudden dyspnea, chest pain, syncope, slurred speech. Lastly, the patient needs to understand the importance of ongoing follow-up care with their cardiologist to ensure the appropriate dose and combination is prescribed for the long-term management of AFib. This concludes my video on AFib. Thank you and have a great day.